We're going to do diamonds and dung, okay? We're going to talk about red, white, and bruised, okay? I thought that was funny. Okay, same goals as before. We're going to review the hematology content areas, and you're going to learn to identify diamonds from the dung for each of the what I call the three big content areas. Red cells, white cells, and then bruising, bleeding, platelets, and bruising, bleeding, clotting, platelets, and coagulation. Okay, we're going to talk, just like I said, reds, whites, and then bleeding and clotting. Okay, we're going to talk about anemia first. And I know that you guys know anemia, but you got to really know anemia because it's going to be on there. And hopefully I can help a little bit with that. I've kind of flipped this one around a little bit. I think sometimes on this heme, I would like to kind of go over a little content and then hit you with a question. So anemia. Anemia is always going to be, look, let me back up. You know, I'm the kind of guy, I don't know how you are, I've never been the resident, the fellow, or the doctor who can create the gigantic Ralph Feigen differential diagnosis. I always like to think simply, you know. I like to think about what the most common things are. I'm a big believer in, you know, you're more likely to see an uncommon presentation of a common thing than you are to see the really rare zebra. So when we talk about some of these issues, I'm going to emphasize them in a simple way because that's what helps me. If it's too simple, send me an email and we'll thresh out, you know, we'll flesh out more details. So anemia is always a problem of production or destruction. And those production problems can be associated with deficiencies in your raw materials, your raw materials, you know, what you need to make red cells. They can also be, your production problem can also, like I say, deficiency, your marrow is the factory. Deficiency, the factory doesn't have the raw materials. Infiltration, the factory's, you know, been destroyed. Okay? The same really, and failure I kind of think of as maybe the workers went on strike. Toxin exposures, yeah, they're just completely different things. Destruction problems, okay? And I really want you to think of destruction problems in a very big way, okay? Destruction problems can be bad hemoglobin, as I call it. Just something wrong with the hemoglobin. Either, you know, it's missing part of the tetramer that we're going to talk about, or one of those chains in the tetramer has some mutation, hint, hint, sickle cell, right? So it can be a bad hemoglobin that's going to give the red cell a shorter life. It can be a defect in the membrane, like spherocytosis or elliptocytosis. Or it can be a deficiency of some of its own machinery, enzyme deficiencies, G6PD, pyruvate kinase. And then the last way that we can get destruction is our body just deciding, you know, let's knock off some red cells with the immune system, autoantibodies. Obviously, you guys know this. It's from medical school, but it's really important, okay? Not only do you classify an anemia by whether it's a production problem or a destruction problem, you classify it by big red cells or little red cells, or normal red cells. So micro, macro, or normocytic. Microcytic anemias, classic. Iron deficiency anemia, anemia of chronic disease, and thalassemias. And we're going to spend a good little bit of time trying to sort out the difference between telling an iron deficiency anemia from a thalassemia. Macrocytic anemias. You know, I just don't see as many of them. In all my life, I really haven't seen much macrocytic anemia. B12 deficiency. I guess it can happen. You know, there's the classic stories of you don't have intrinsic factor, you have all these things, but I haven't seen them. Folate. how do you get folate deficient these days? I almost mean that in like a parse. I mean, don't we put folate in everything? I mean, except for the water, I guess. We have, just about every food is, pardon? Goat's milk. You're right. Yeah, I forgot. You're right. But, can we all agree you got to work at being folate deficient? I apologize. I should have had my goat's milk hat on because that's a classic. But who has seen folate deficiency from goat's milk? In questions. I'm talking about in humans. Okay, good. I'm proud. I haven't. Okay, all right. That's cool. But again, we're all in agreement. You got to work, and you got to work. But you can see macrocytic anemia. Actually, the most common time I see it is associated with drugs. And we'll talk a little bit about that. Okay. So, audience response 1. 2-year-old girl for the first time. On history, you discover that she's drinking 36 ounces of milk per day. Okay. Ouch. Ouch. Can I have him removed? Score 1 for you. All right. Okay. So, we know what her diagnosis is, okay? Or we better know what her diagnosis is. You've given a big diamond. Now you have to tie in some information about this type of anemia, okay? So which of the following statements is likely not true about a certain kind of anemia that you're thinking that this child has because of 36 ounces of milk? They have a low hemoglobin. Okay, well, I already said it was an anemia. So you know that's going to be true. Their platelet count is big. Their MCV is something. Their reticulocyte count is something. And their RDW is something. So which of those is not going to be true? Okay? Okay. All right, we'll reinforce this like we did in the oncology. We're going to say a couple things, do some questions, and good. All right. Oh. All right, I'm gonna get a note from it, but you guys will get this one completely right next time, okay? But you learn from, I had a cranky old professor. I was a chemical engineer before I went to medical school, worked for 8 years, and a cranky old chemical engineering professor who taught in the Socratic method, and he would call on us, and you had to answer. Because he said, you can learn from a right answer, you can learn from a wrong answer, you cannot learn anything from an I don't know. I don't know is not an acceptable answer. So unfortunately, this is a wrong answer. And we're going to have to learn from it, okay? So this kid's got iron deficiency anemia, right? And in iron deficiency anemia, you're going to be iron deficient. When you have iron deficiency anemia, you can have thrombocytosis, okay? So that can definitely be true. I look at thrombo. I'm like, oh yeah, I just got to correct their iron deficiency. Those platelets will come back in line. MCV, is that a low MCV? Is that what you'd expect with iron deficiency anemia? You bet. Reticulocyte count 1%. That's kind of a trick question and kind of mean. The guy who put that in there is mean. And it is that, reticul 1% is kind of normal, but but it's going to be true because it's, you're going to make some kind of retic, 0.5 to 1%. You're not going to have a big retic because you don't have the raw materials to make that reticulocyte count. What the point I want to get to here is the RDW. The RDW is the distribution width. So when we talk about red cells, we talk about their size. But not every red cell is 68 femtoliters, They're not all these same size, right? And so when you look at their size, you describe it as a distribution, okay? And a typical distribution has a certain width, okay? Probably based on the standard deviation. In iron deficiency, that marrow is unhappy because it doesn't have the raw materials and it's throwing out cells that look like crud of all different sizes. So that distribution width is going to be large, okay? Routine examination, 1-year-old boy, noted to be pale. 75th percentile for weight, 25th percentile for height, Physical exam, otherwise normal. Hemoglobin 7.4, white count 7, platelet count 750,000, reticulocyte count 0.5%, sickle cell testing negative, stool guaiac negative, MCV 65. Now, I can't remember which friend helped me make this question, but, obviously, one of the things that you would really want to do in terms of being a good guy is order one particular test that's not on here, okay, to kind of verify your diagnosis. But, let's give him 36 ounces of milk as well, too. And what do you want to do next for him? Okay, please don't transfuse him, okay? Because he's not, he has to have clinical signs and symptoms to be transfused. Start him on iron. Iron fortified cereal, nah, all in. Let's go all in. I just don't see iron fortified cereal as the right answer. Not, these questions can be a little read my mind, and you would like to know what his ferritin is, because ferritin is a measure of the total iron body stores. It can be a little confusing because it's an acute phase reactant as well, but it is a measure of the total iron body stores. And let's say his ferritin was 2. Okay, you going to fix that with iron fortified cereal? Okay. Iron deficiency anemia, dietary. Come on. Everybody in here has taken care of the toddler who drinks too much milk. Blood loss, irritation from cow's milk protein. Meckel's diverticulum is kind of a classic one to think about for a cause of blood loss. Ulcer, polyps, hemangioma, worms. I've been lucky. I've never had to take care of worms, and I'm not really wanting to sign up for that. You can get inhibition, decreased absorption, celiac. That's kind of a common one that can be tied to that. Your clinical features are pica, eating things that aren't nutritious. Can be tachycardic, can have a murmur. We could argue about whether having a gallop is an indication to transfuse. If you got a hemoglobin of 4 and a gallop, there are a few hematologists I know who would give you iron and send you home, but most are wimpy like me and would probably transfuse at that point. Impaired growth, cognitive dysfunction, altered attention span, behavior, performance, So that's why you can't mess around with iron deficiency. Kids can get really hurt by it. Small cells, lots of different sizes, okay? RDW is the width, is the spread. How many different sizes do we see? Anisocytosis, poikilocytosis, different sizes, different shapes. Normal to low reticulocyte count. It's not going to be elevated, right? If the marrow's, if something happens and your marrow you're anemic, your marrow's going to turn on and make retics, right? If everything's good. But if it doesn't have the raw materials, it's not really gonna. So your retic is going to be normal, which is not normal for having anemia, correct? Or it's going to be low. And thrombocytosis, okay? See it all the time. Management, oral ferrous sulfate. Identify and correct a cause. If there's, get rid of that milk. How many ounces of milk you limit them to? 16. No more than 24 for sure. I like to say 16. Red transfusion only for severe anemia, and giving iron intravenously only after they fail oral. And, that is kind of where you might end up with your patients who have celiac disease. That's a possibility. Okay. This you can see, and I would challenge you to say that, this is what you ought to be able to recognize this as iron deficiency anemia. Small, lots of different sizes, lots of different shapes. How's that central pallor look to you? Way too big, right? Okay. Any question on the smear? Okay. Okay. Classic picture of iron deficiency. Hypochromic microcytic RBCs. Notice the increase in platelets. Did you notice them? Okay. Well, remember, I think, what is it, on a high-powered field, you're going to see about 5, isn't it? 5, 6. You're going to see a few. There are a lot of platelets on this high-powered field. We'll go back and take that off. Those are a lot of platelets. They're kind of big too, so it's your marrow working. It's like what happens is the marrow kicks into overdrive, but it doesn't have the raw material that it needs to make red cells. Okay. We're going to treat it with oral elemental iron. If you're really anemic, I'm going all in. I'm going somewhere between 3 to 6, and I'm going to retest after 4 weeks of therapy. If you're really anemic, I'm going to bring you in sooner, maybe after 2 weeks, to start to see if some corrections. You're going to see an increase of hemoglobin by at least 1 gram or a 3% rise in hematocrit. You'll continue probably for 2 months, and if you've corrected, you'll check after a month, continue for 2 months. You'll want to continue until the ferritin. That's the last thing that's going to correct, right? Ferritin, total iron body stores, last thing that's going to correct, and you might continue a little past the ferritin, being normal. Okay. You'll want to continue to follow up and make sure any dietary changes you've put in. I think I got this out of your reference books and syllabus. Breastfeeding is good because the iron, although breast milk is low in iron, it's highly absorbable. If you're exclusively breastfed, you're going to start iron supplementation after 4 months of age. Start it earlier with preemies. Infants who are not breastfed must be on an iron supplemented formula during the first year of life. And iron-enriched cereals should be among the first foods. Never, ever use cow's milk during the first year. You're going to have that allergy. You're going to have a mild, kind of subacute colitis with bleeding. Okay. Iron deficiency and lead poisoning. Typically, it goes the way of you get iron deficiency, you get pica. Pica involves eating clay and other non-nutritional substances. Pica is usually the link between IDA and lead poisoning. I've never really practiced in an area. In Houston, we didn't have anything old. It's just true, right? In Texas, there's nothing old. So, compared to the guys who came from the Northeast, I knew nothing about lead. Iron deficiency anemia increases your absorption of lead, and lead being greater than 45 micrograms per deciliter is the indication for chelation. Okay? We're going to see some coarse basophilic stippling in lead poisoning. Notice it any place? Okay? All right. And that's kind of classic for lead poisoning. Any questions on iron deficiency anemia? You will have questions on iron deficiency anemia on your exam. Know it. Routine screening, complete blood count of a 1-year-old noted to have a hemoglobin of 7.4 and an MCV of 64. A follow-up hemoglobin electrophoresis demonstrates an increased concentration of hemoglobin A2. Okay, so clearly, where's the diamond in this question? The increased A2. You have to be able to tell me what A2 means. Okay? Hey, you guys decided you'd be nice to me today. Yes, that's beta thalassemia. And we're going to talk more about the thalassemias and more about hemoglobin structure. But I'm glad everybody's on board on that. So hemoglobinopathies. Okay, remember, they're a cause of anemia. They're bad hemoglobin. They can be either you don't make enough of some part of the hemoglobin, or you make a part of the hemoglobin in not the correct way. So a hemoglobin is a tetramer. Everybody remember that? Your normal kind of grown-up good hemoglobin contains 2 pairs of alpha, contains 2 alpha chains and 2 beta chains, and is designated as alpha 2, beta 2. Fetal hemoglobin, making in utero, you have 2 alpha chains and 2 gamma chains. Fetal hemoglobin, hemoglobin F. Hemoglobin A2 is a minor adult hemoglobin, and it contains alpha and delta chains and is known as alpha 2, delta 2. So as I keep beating into your heads, and I want you to really understand, a hemoglobinopathy can result from either a mutation in the globin chain, that means there's a change in that, or there's a decreased production of one of the globin chains. Okay? All right, let's try to make this a little more. Let's talk about the thalassemias. Thalassemia is not one of the globin chains has got a problem with it. It's just not there. There ain't enough of it. And so these are inherited disorders of globin chain synthesis. And our problem is that you don't have a balanced production of synthesis. Your number of alphas and number of betas don't match. It can be caused by absent or decreased production of either the beta part or the alpha chain. Okay? It's a little important, and when I did this in years past, I think I did a crummy job. So I want to do a really good job this year. And if you think I do a crummy job, write it down, and I'll try to do a better job next year if they decide to invite me back. So you need to know a little bit about the genetics to really understand your thalassemias. There are 2 alleles each on chromosome 16 for the globin chain. So you got 4 alleles. Okay, there are 4 alleles that are in charge of making your alpha chains. You have 1 allele each for the beta globin chain. Okay, so you just got 2 running around. And I think this is going to help us understand the beta thalassemias better and understand the alpha thalassemias better. This is where I was a chemical engineer before I went to medicine. I wasn't a big biology guy. I hate genetics. But here we have to understand kind of the genetic basis, because it's going to help us understand these, diagnose these, distinguish them from other problems. So beta thalassemia. You can have beta thalassemia trait, or sometimes called beta thalassemia minor. These are people who are heterozygotes. They have 1 normal allele and one thalassemic allele, meaning they're not making enough of the beta chain. They will have mild anemia with a disproportionate microcytosis. Their RDW is going to be normal, but they're going to have extra A2. So that was the question we asked. Okay, if you're ever stuck and you got a complicated patient and you're trying to sort out whether they got a thalassemia, the first thing you have to do is you have to take iron off the table. Okay, because remember, these are microcytic as well. So what you have to do is you have to look at iron, and if they're iron deficient, you got to correct their iron first, and then do your hemoglobin profile or hemoglobin electrophoresis. Okay? That's kind of a test pearl, but more really a pearl for clinical practice. Okay? Beta thalassemia major. That's homozygosity with no globulin production. They make a lot of highly insoluble globin you're unbalanced, right? You're not making enough beta, so you get a bunch of alpha chains, and they precipitate into inclusion bodies. This is severe clinical symptoms. Infants show pallor, irritability, growth retardation. They get a lot of extramedullary hematopoiesis, and so they'll get big spleens because the cells are all crummy. They're going to break down, and they're going to get jaundice. They get expansion of their marrow spaces because the bone marrow is trying to go crazy, making things. And they'll get, the facial expansion in the facial bones, leading to chipmunk facies. And their electrophoresis is going to show a lot of hemoglobin F because they're not making beta chains. They're transfusion dependent, and whenever you're transfusion dependent, you are at risk for iron overload. And what do you do for iron overload when it gets bad enough? Chelate it. Okay. You can have an intermedia. That's like, okay, you got the 1 gene out, but the 1 bad gene still makes some normal beta globin, and that's a milder symptom. They don't require transfusion. They'll have decreased production of beta globin, leading to an increased delta and gamma. So what's going to distinguish intermediate, which I've just thrown in here, versus major? Okay, we said in major, you're not making any beta. So if you're not making any beta, you're not going to see any hemoglobin A, right? Alpha 2, beta 2, the normal hemoglobin. If you see a little bit of A and you haven't been transfused, then you fall into this category called intermedia. Okay? All right. Okay, alpha thal. You got 4 genes for alpha thal. Okay? We're going to make it simple. We're going to talking about the number of genes that have taken a hit. 1 hit, asymptomatic, no hematologic abnormalities. 2 hits, okay? They can be on the same chromosome. They can be on different chromosomes. All that really matters is for genetics and family planning down the road, okay? So if you have 2 affected, these patients have very mild anemia. They're asymptomatic. Their iron is normal, but their MCV is low. Should you give them iron? No. It's a bad thing, okay? If you get into having 3 loci affected, well then you're going to have some bad-looking hemoglobin, okay? Because what's happened? You got 3 loci affected. Now your balance is way out of whack. You're not making enough alphas, and you got too many betas running around. So you can get HPH, or hemoglobin H, is beta 4. Remember we said hemoglobin, tetramer, you need 4 chains. Well, if all 4 of those chains are beta, it's called hemoglobin H. And that's hemoglobin H disease. And you can have moderate to severe hemolysis. If you got all 4, you end up with hydrops fatalis. And, in sorting out thalassemias, remember, let's go back. I'm just going to go back. I apologize. But I think understanding your hemoglobin as a tetramer helps you understand these things, okay? If you're a baby with some kind of thalassemia and you're not making enough alpha, your alpha production's down, well, you're going to have trouble making your fetal hemoglobin. And instead of filling in 2 of those alphas, you might end up with 4 gammas, which is hemoglobin Barts. So hemoglobin Barts on a newborn screen is going to be a hint that the patient has alpha thalassemia. I consider the thalassemias to be very challenging. I hope what we've just done in these slides has made them less challenging. I think the key is to think about what hemoglobin is, a tetramer. Think about what what the most common normal adult hemoglobin is. 97% of your hemoglobin is hemoglobin A, alpha 2, beta 2. Think about the genetics. What happens if I don't make enough alpha? What happens if I don't make enough beta? And I think if you go back to that basic of understanding what the hemoglobin tetramer is, and then start thinking about what could go wrong with that tetramer, understanding alpha thalassemia, understanding beta thalassemia becomes a lot easier. Okay. I hate the Metzner index. I think it's worthless. Okay? But it shows up in a lot of references. But if you go to some good references, they'll tell you it's not reliable. Okay? So I've put this stuff on there. I'm not going to talk about it. What I do want you to know is that iron deficiency and thalassemias are on your microcytic anemia differential, and you have to work at distinguishing them. Okay? Iron deficiency anemia is going to have a low iron panel. Okay? Check your iron. Low ferritin. Ultimate measure of total iron body stores. Okay? All right. Thalassemia. For beta thalassemia, the ultimate test is going to be hemoglobin electrophoresis. Okay. For alpha thal, not really the case. For alpha thal, it's really going to be more by history and by eliminating iron deficiency anemia from the diagnosis. The patients that I've taken care of with alpha thalassemia usually come in and tell me they have alpha thalassemia because someone in the family has had alpha thalassemia. But if you don't, you sort it out by getting rid of the iron deficiency anemia off the table. You're left with a microcytic anemia, a mild microcytic anemia with normal iron stores in a well-appearing child who doesn't have anemia, chronic disease, does not have an elevated hemoglobin A2. That's going to be alpha thalassemia. Okay? All right. 6-month-old girl, born in Nigeria, presents to the office with fever and irritability. Physical exam reveals a fussy infant who has anorexia, a temperature of 100, and swelling of all the fingers of the right hand. Okay? What does this child have? Don't look at the question. I want you to tell me what this child has. Somebody shout it out. There's a great word. Dactylitis. You got it. Okay? And if you've got dactylitis, what caused it? All right. Okay. I just like this question. I know it's kind of simple, but I like it. Somebody wanted to be a wise guy. Okay. But dactylitis is a classic early presentation of sickle cell, okay? And you need to know it, okay? 13-year-old boy with sickle cell disease presents to the emergency department with fever, cough, shortness of breath, chest pain, and bilateral infiltrates on chest x-ray. And this is just a simple, straightforward teaching question that I like about sickle cell. All right, and I'm going to teach a lot of things about this. We're going to use this question to teach. Okay. Okay. Uh-oh, I'm in trouble. You know, all these answers are good, but let's talk clinically. All right, what does this child have? What's the difference? Somebody courageous raise their hand and explain to me in 100 words the difference between acute chest syndrome and pneumonia. Thank you. All right. I know I love to ask that and pimp on rounds on that. But there isn't, okay? You don't know. There is no difference. What is the most common cause of acute chest syndrome? I don't know. That's what it is. Unknown or undetermined. We don't. But so maybe this is a crummy question, and when I do this next year, we'll throw this one out. But let's learn from this crummy question, because there's a heck of a lot to learn here. Patients with sickle cell, do they have spleens? Do they have functional spleens? If they have SS, they don't. SC, maybe for a little bit, but SS disease, the most common form of sickle cell, no functional spleen. Do we worry about strep pneumonia? Yes. Are we going to cover for it? Yes. Okay. There's a famous New England Journal paper, and if I keep this question, I'll revise it and cite it, that asks for the most common cause of acute chest. And the most common cause of acute chest is letter E. The most common cause of acute chest, if you identify a pathogen, I think this might have come from autopsy series or something kind of gruesome like that, is what? Chlamydia pneumonia and mycoplasma pneumonia. So what do you put all your sickle cell patients on? Right? You put them on a cephalosporin, you put them on azithromycin. Right? Does this sound like bread and butter? Pediatrics, done this on the floor a million times. Okay? But you guys know this, so let's go. Fat embolism. Everybody talks about it. I've never seen it proved, but we talk about it as a cause. The bony infarcts. Yeah, the bony infarcts in the chest are definitely part of this acute chest syndrome. But we really never know the cause of acute chest syndrome. So what we're going to all say is, yes, this was whatever naughty word you want to use, crummy question. But hopefully Thompson taught you a little bit even using this crummy question. And that maybe this crummy question is going to help you answer a good question on the test. Hopefully we can all be in agreement on that. Sickle cell anemia. Remember, we said anemia, anemias, when we talk bad hemoglobin, are thalassemia, I'm not making enough of one of the chains. Sickle cell, I got a mutation in one of my chains. So sickle cell anemia is a mutation in the beta globin gene, okay? And you get sickled red cells with shortened survival, and that's why you get anemia, elevated retics. What do you often see with their white count? Raise your hand if it's up, put your hand like that if it's down in a patient with sickle cell, right? You're going to see them up. You're going to often see them up. Okay, lab features. Normocytic anemia, yeah. Sometimes microcytic with hemoglobin SC. Increased reticulocyte count, darn straight, that's what they live at. Thrombocytosis, possible. Leukocytosis, definitely. Peripheral smear, sickle cells, polychromasia, Howell-Jowl bodies, hemoglobin profile. You're going to have a lot of hemoglobin S. You kind of have to know the trends. Are you going to have any hemoglobin A? No, not in sickle cell disease, right? Because both beta genes are mutated. If you got trait, you're going to have a hemoglobin A. But in disease, you're not going to have any hemoglobin A unless you got transfused. So the only way, if you have a patient with hemoglobin SS disease, okay, and they get an electrophoresis on them, and it's got A in it, what does that tell you? That's somebody else's A, okay? Okay. All right. They're going to have a lot of F. And what drug do we use to sometimes increase that F? What else does hydroxyurea do? Lowers counts. Particularly, it's thought to maybe even be some of its benefit comes from lowering the white cell count. Okay. So this is our slide for sickle cell disease. You darn well better be able to pick that out. Okay. Okay. Sickle cell, clinical features and management. Hand-foot syndrome, vaso-occlusive crisis, acute chest, hydration, analgesics, red cell transfusions. Where I grew up, simple transfusion, was the first step. We went way down on exchange transfusions by being aggressive. The other thing I would add here is a lot of good pulmonary toilet, okay? And that can also include things like bronchodilators, okay? The antibiotics have to include a cephalosporin and a macrolide, azithromycin. Splenic sequestration. Red cell transfusions, we tend to go on the low side in terms of the red cell transfusion, in terms of the volume. Why? You worry a little bit about autotransfusion, kind of all of a sudden getting all the red cells out of the spleen. Aplastic crisis, you red cell transfuse as well. You're much more aggressive. You can treat it, as my mentor Don Mahoney used to say, like it's a gunshot. Stroke. I think it's pretty important that we know that we do transcranial Dopplers to look at flow through like the middle cerebral artery and the whole thing's up here, and we base our velocities. Either being too fast or too slow makes us worry. And when we have worrisome transcranials, we will often start a patient on scheduled transfusions. Priapism, hydration, red cells, transfusion, irrigation, and surgery if really bad and necessary. I probably didn't spell it out, but I think most of what we talk about with sickle cell disease is hemoglobin SS. I actually hate it, despise it when I see written in the chart that a patient has SCD, sickle cell disease. It drives me crazy, okay? Have I done it? Yeah, but it still drives me crazy, okay? It's much better to actually say, what is their hemoglobinopathy? Is it SS? Is it SC? Is it SD? Is it S beta plus? Is it S beta 0? Okay? Those last two down there, are we familiar with the terms S beta plus and S beta 0? Okay? S beta plus, okay, so what happens? So one of your beta globulin genes, you have the mutation you have the S mutation that gives you hemoglobin S. On your other beta globulin gene, you either have the thalassemia mutation where you're not producing any beta globin genes, or you're producing just a few beta globin genes. Okay? So let's think this through. All right. If you have S beta 0, you're not making any beta globin genes, is that going to clinically look like SS? Yeah. Because all you're going to have is hemoglobin S. But if you're making some beta, you're not going to look as much like hemoglobin SS, and you're going to typically have an elevated hemoglobin A2. Okay? So make a little note on that. S beta plus, elevated hemoglobin A2. All right. So we've talked about bad hemoglobin. Let's talk about the way other things break. 4-year-old, previously well boy of Middle Eastern descent develops pallor, dark urine, and jaundice. He is taking he's taking Bactrim. I know I'm not supposed to say that, but I have a terrible time pronouncing that, for otitis media, and he's eating fava beans as a snack. Damn it, you better get this question right. Okay. All right. Somebody wants to give him hereditary spherocytosis. Make the group look bad. Okay. So this is the classic G6PD story. Okay. Can be seen in African Americans, Asians, Arabics, Mediterranean populations, can be mild to severe. Hemolysis is triggered by food and drugs. Anti-malarial drugs are classic for this. And there's one oncology drug that can trigger this. Has anybody ever seen given rasburicase for tumor lysis? You can do that. It's really kind of scary. Management, prevent the exposure. Transfuse them if their hemoglobin gets low enough. It's really more exciting as a board question than as a disease a hematologist treats, though it can present with severe enough anemia that these patients will end up in an ICU, especially if you have a conservative institution that puts a lot of people in the ICU. 3-day-old infant presents to the emergency department. Okay. Sorry. I made this question up based on a patient I saw in residency. I want you to learn from this question. 3-day-old infant, emergency department, hypertonia, arching of the back, high-pitched cry, lethargy. Lab results show the bilirubin is 28.7. Family history is notable for the infant's father and uncle both having a history of splenectomy. They could pull their shirts up and show you their scars for anemia. What is the most likely cause of this patient's underlying condition? And also, what does he have that's got him hypertonic, arching his back and that? Okay, so please pay attention. This one I would like 100% right. Okay. He's got spherocytosis. Okay. The clinical disease he has that we're talking about right at the moment in the NICU, or when I got him in the NICU, was kernicterus. Okay. It's what you always want to avoid with the elevated bilirubin. It's the big bad thing that I had never seen and have only ever seen that one time in my life. And it's horrible. And you don't know what his long-term outcome is going to be. Probably terrible. It was a Spanish-speaking family. Someone didn't get the history. They could have elicited it. I speak very bad Spanish, and, even if they don't know what the anemia is and they're showing you a splenectomy scar, what are you thinking? you're thinking hereditary spherocytosis. Remember, autosomal dominant, we're going to talk more about that. This was really heartbreaking to me. Hereditary spherocytosis, autosomal dominant. They like to ask this. I think it's stupid, but I have to look it up every time what proteins are involved in the membrane being bad. The most common is spectrin. The most common other mutation is in ankyrin. These are proteins that give the membrane its beautiful normal shape. It can be a very important, serious cause of neonatal jaundice. I think all the kind of real experienced pediatricians, will tell you that their worst neonatal jaundice stories are probably related to hereditary spherocytosis. I like this one because it's kind of classic. I didn't used to do as much heme when I was at TCH, and I've been doing more heme in North Carolina. And so you really learn, you can do osmotic fragility. It takes a while to come back. Some hospitals do it terribly. Carolina has this tremendous tradition of excellence in heme, so we get great osmotic fragility tests. But you can often make the diagnosis just based on some simple lab findings. And those are, does the patient have an increased retic, right? Because if you got spherocytes, they're falling apart faster, and their retic's going to go up. And do they have an increased mean corpuscular hemoglobin content, MCHC? Why? Remember, when you're making this a spheroid, okay, your volume is actually, with this membrane defect, the volume of the red cell is smaller. So you can just think of the hemoglobin as being crowded into a smaller place. So I had these twins, again, parents way smarter than me. They come to me and they're saying, do our children, dad's got hereditary spherocytosis. We made it through the neonatal period with some bilirubin lights and jaundice. We think the twins have hereditary spherocytosis. Can you confirm the diagnosis? And even before the osmotic fragility came back, I called them up and said, yeah, they got hereditary spherocytosis. They both got big retics. They both have an elevated MCHC. Management is really expectant. I don't know how else to describe it. Remember, the cells have a short half-life. So just like in sickle cell disease, what do these people depend on to live? Their reticulocyte count. They depend on making retics. So if something happens, if they get a virus, if they get a certain virus that has a letter and a number in it, that causes really bad marrow suppression. Can they be in deep doo-doo? Yes. So, management, sometimes we do splenectomy. We do splenectomy for, chronically big spleens. We do splenectomy sometimes, just if they're really living with a really high retic, and the marrow's really stressed, we'll do it. We'll do it for enough aplastic crisis. We'll do it for, hypersplenism, for splenic sequestration, and for a big retic. Okay, do you see the spherocytes? Okay, there is no central pallor. You can always see spherocytes out on the thin edge, right? Okay, if you go out too far, you'll see them on a smear. But these are spherocytes. They're a little bit smaller, right? See how they're a little bit smaller compared to the nucleus of the lymphocyte? Okay. 13-year-old boy, increasing fatigue several days after a URI. Findings include pallor, scleral icterus, and a palpable spleen. Laboratory studies show anemia, retic. What do we think about that? Billy, what do we think about that? LDH, what do we think about that? And I always think that this is a diamond in a question, is if they tell you that something was normal in the past. Okay? All right? So let's think about that. What lab test is going to be most beneficial? Okay. 10% of you said hemoglobin electrophoresis. Okay. If they had electrophoresis is what we're doing when we're looking for an oddball hemoglobin, meaning a hemoglobin that's formed because one of the chains, one of the beta chains has a mutation, like sickle cell disease, or one of the beta chains isn't being produced enough, right? Is that a chronic, you're born with it kind of problem? Yeah. So is hemoglobin electrophoresis going to be helpful in this acute problem? Probably less likely. G6PD, we're not giving him any exposures, Could it be on your radar? Yeah. Erythropoietin level? No, I don't even remember if I've ordered one ever. Osmotic fragility? No. That's going to be something I'm working up in the little kids. And they're going to, if I'm thinking hereditary, osmotic fragility means you're thinking hereditary spherocytosis. And if you're thinking hereditary spherocytosis, you're not thinking this clinical scenario. The clinical scenario here you're thinking, which 82% of you got, is you're thinking about some kind of autoimmune hemolytic anemia, right? Sudden onset, URI, crazy LDH, all those kind of things. Autoimmune hemolytic anemia just kind of can sometimes happen with association with drugs, kind of as a secondary thing. Can be associated idiopathically on its own, or like I mentioned, it can be like a paraneoplastic syndrome in some cancers. Often preceded by that viral infection, acute hemolysis, severe anemia. Big retic. One little caution on the big retic. If you catch these patients really quickly, is it possible that they might not have a big retic? Yeah. It might take the body a little bit of time to mount that reticulocyte count, to mount that retic response. Hyperbilia, yes. Hemoglobinuria, yes. Mild splenomegaly, Coombs test positive, steroids transfusion. Can be warm antibodies, can be cold antibodies. I didn't put this in there. I kind of think of this as a heme level question, but I'll throw it out there just for you to write down in a note. Warm antibodies, kind of classically IgG. Hemolysis is extravascular, typically in the spleen. Cold, IgM mediated. Hemolysis is typically intravascular. And so you can see elevations in plasma-free hemoglobin. Okay? You're not going to see elevations in plasma-free hemoglobin if the hemolysis is occurring extravascularly in the spleen. Okay? White cell disorders. Basically, we can have issues with morphology, function, or number. Morphology, I don't know. When you talk about these, I think these are more like kind of interesting things, not really diseases all that much of the time. You can have toxic granulation, which you're going to have when you're fighting an infection. You can have a Pelger-Hewitt anomaly, which means nothing. You can have hypersegmentation, which is related to what? What kind of milk were you drinking? The goat's milk, okay? Function, that's mostly I consider an immunology topic, but you can have neutrophil disorders, which, involve phagocytosis. What don't we, isn't there like a classic neutrophil disorder that we think about when the umbilical cord doesn't come off? Okay, all right. Lymphocyte disorders, though, can be congenital or acquired in the function. Number, that's really kind of the more important to me. I think if we're going to get some real diamond out of this area, I think it's benign versus serious neutropenia. You can see toxic granulation, Dolly bodies. You'll see a left shift, and the Pelger-Hewitt anomaly, like I said, is a hyposegmented neutrophil, and that is a benign condition. Toxic granulation, fighting an infection. Dolly bodies, the blue arrows. Can you see my light blue arrows? I'll switch and get a darker arrow, but that's a Dolly body. Toxic changes in left shift, that just means you're throwing bands out or other early myeloid forms. Really bad infection. Pelger-Hewitt anomaly and a Stadmeister cell. Boring. Okay. An otherwise healthy child who drinks regularly has a CVC checked at his 1-year checkup. The peripheral smear shows the following. And I think I got these goofed up, and I apologize. I meant to bring them up. So we're gonna guess. You'll see it, but take a guess on what their issue is. And if anybody gets this wrong, you're just plain being contrarian, given how much we've already talked about this. Okay, contrarians. I'm not even going to talk about those answers. Okay. Macrocytosis and hypersegmented neutrophils are what we see in folate or B12 deficiency. Okay? All right. Hypersegmented neutrophils. How do you like them? Okay? Folic acid deficiency. I promised you I'd get to it. Goat's milk. Never talked so much about goat's milk in my life. Defects in absorption, small bowel disorders, inborn errors of absorption and metabolism, drugs. This is much more common if you're going to talk about folate deficiency and, macrocytic anemia associated with this. I mean, when you're treating a leukemia patient, I want them to see it. I want their MCV to be a little bit elevated because I'm giving them methotrexate, which interferes with folate metabolism, and I want to see that MCV elevated a little bit. If you're folate deficient, you're not going to have neurologic symptoms. You're going to have a macrocytic anemia, your hypersegmented polys, neutropenia, thrombocytopenia, everything we're trying to achieve, neutropenia and thrombocytopenia when we're treating somebody with methotrexate. If you're not treating them for cancer, supplement their folate, okay? Identify and treat the cause. Stop the damn goat's milk, okay? B12 deficiency, very similar to folate deficiency. Macrocytic anemia, neutrophil abnormalities can be associated with pernicious anemia, will have neuro symptoms. You got to check for B12 even if you think in folate, because if you supplement folate, you can correct the anemia but not fix the true B12 problem and have continued neurologic problems. Okay. 14-year-old girl develops fever, sore throat, and enlarged cervical lymph nodes. Her peripheral smear is shown on the next slide. What is the most likely diagnosis? We're going to skip this. You're going to mark, when you see this, you are going to mark that she has C. The answer to this is letter C. Okay? Letter C. Thank you. Thank you. I love you guys. Okay. All right. Why are these not blasts? They're big. Okay? Or why wouldn't we think they're blasts? Remember what we talked about for a blast. A blast is going to be big. These are big. Blast is going to have a high nuclear to cytoplasmic ratio. These have lots of cytoplasm, right? So that's why it's not a blast. And they're not all going to look like private school kids. Your smear or your bone marrow, whatever, wouldn't look like a bunch of private school kids. You can get a reactive lymphocytosis, get these funny looking lymphs that the pathologist may comment on, that the hematologist may tell you about. You can get them really with respect to any viruses, EBV, CMV, all those. You can get them really with respect to anything, and even stress. And I don't know where I read that, but I don't know. Okay. Since 8 months of age, a 13-month-old boy has had several repeat CBCs, which have shown a white blood cell count of 2,400 to 3,000 and an absolute neutrophil count of less than 400. A recent bone marrow aspirate shows granulocytopenia with normal trilineage precursors. Okay, what the hell does that last sentence say? Okay, what it says is you're not making the final granulocyte, but you got the precursors. Something's happening, to the final granulocyte, to the final neutrophil. So what is this condition? likely, and then what's the pathophysiology of this condition. Okay? All right. You guys, you've got looked at your choices. I'm not going to read them. I'm getting tired. So let's fire away, and let's get it correct, or else I'm going to be cranky. Not really. Okay. Very good. This is autoantibodies to granulocytes, and that's what the whole thing on the precursors are saying. Bone marrow failure, it could not be bone marrow failure, because the definition of bone marrow failure, when we talk about it, is not having enough red cells, not having enough white cells, not having enough platelets, and not having enough cellularity to the marrow. Okay? You have reticulocytopenia in bone marrow failure. You ain't making reticulocytes. You have low white cells, you have low platelets, and when you look at the marrow, it ain't cellular. Okay? So this is autoantibodies to the granulocytes, and this is what's known as chronic benign neutropenia. It is the most common cause of neutropenia in healthy children. Did this stem of this question say this kid had repeated infections? No. If this kid was having repeated infections, would he have a disease that has benign in it? No. Okay? All right. We can diagnose it sometimes with anti-neutrophil antibody, usually positive. The bone marrow exam, maturation arrest at earlier stages. Remember, you're not getting to the final neutrophil. Management, treat it if it gets an infection, counsel the parents. But the number one treatment on this is reassurance, self-resolving. Okay? And like I said, classically in that 8 to 11 months, usually gone away by their just past their second birthday. So if that is benign neutropenia, what I want you to understand is the not benign neutropenia. Okay? Cyclic neutropenia. Whew, I find this hard to diagnose. I'm not sure I've ever accurately diagnosed it. I know my colleagues have. And that means you're getting neutropenia that occurs roughly at a 3-week cycle. It's characterized by defective maturation. You can have stomatitis, lymphadenitis, and severe infections. Why does somebody get stomatitis? They don't have neutrophils. Your neutrophils are cleaning machines, okay? And they take care of your mouth and produce your mouth health. When you took care of my oncology patients in residency, what happened when they all had mucositis? When did the mucositis go away? When the neutrophils came back, okay? And when their mucositis was improving, what would I tell you? Their counts are going to be up tomorrow, okay? Kosman syndrome. Inherited disorder due to mutations in a couple different genes. Classically, a very severe neutropenia, less than 200. Got to be treated with G-CSF. Important in that it can transform into myelodysplastic syndrome and AML. Schwachman-Diamond, autosomal dominant, neutropenia, failure to thrive, pancreatic insufficiency, needs bone marrow transplant. Okay. Routine screening, CBC, 1-year-old is noted to have abnormal differential. The smear is prepared for review. Boom, okay, it's got a lot of red things on it. This came to me as a PDF. I didn't have my act together with them, All right. It's going to be parasites, okay? All right, thank you. Okay. Why did those of you who answered the question answer it correctly without reading? You had looked ahead. You had seen these cells have lots of red stuff in them, which is eosinophilic. So these are eosinophils, and you get them with parasites, classically. Okay? Not always, but you can get them with asthma, hay fever. But if you're going to get a lot of them, it's going to be with invasive parasites. There's a really bizarre type of ALL, not AML, ALL, that does something crazy that puts the gene that drives, I think it's IL-4, IL-5, that turns on your eosinophils, puts that under the production, has some chromosomal rearrangement that cranks that up, and they can have eosinophils kind of as a paraneoplastic syndrome. The eosinophils aren't leukemic cells. They're just in response to the leukemia cells. So eosinophils can sometimes be associated with cancer. But again, allergies, see them in dermatitis, infections. If there's one thing you're going to think of is parasites, you can see them in some crazy kinds of cancer. You can see them in GI disorders, hypereosinophilic syndromes. Those are really bad. These things really want to help you make clots. They can give you all kinds of pulmonary problems, and you can see them in some miscellaneous immunodeficiencies. Okay, the last thing we're going to do is bleeding and clotting. Common bleeding scenarios. Platelet. I think the thing with bleeding is it's not always true. It's not 100% true. But I think what you want to do is you want to associate, both clinically and on tests, the type of bleeding issue you're seeing with where you think that disorder is most likely going to be. So if the problem is your platelets, it's going to be primary hemostasis. So that's spontaneous bleeds. That's stuff like nosebleeds. That's stuff like hematuria. So if you either have too few platelets or platelets that don't work, you're going to see spontaneous bleeding, nosebleeds, hematuria. Think about it. What do ITP patients show up with? Spontaneous mucosal bleeding sometimes, nosebleeds, maybe hematuria, because they have primary hemostasis issues. They don't got any platelets. Factors, okay? If you've got a factor disorder, what does it show up as? Well, okay, circumcision when you're really young. But it's usually problems with secondary hemostasis. So what do you think of? Joints, 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 right? Okay, you're going to think of joints. Okay, all right. The other one, and I really, I don't know how long it took me to appreciate it, and I hope with your training, hopefully you've been smarter than I was in my training and realized that menorrhagia with first, second cycle is kind of a classic presentation of von Willebrand's disease. And so I'd like you to tuck that away as a diamond to think about. Okay? So again, think of what you have, match it to where the defect might be. Okay, primary hemostasis, got to be platelets. Now I'm thinking, is my problem that the kid has not enough platelets or something wrong with his platelets? Okay. 2 weeks after a viral syndrome, a 3-year-old child develops bruising, generalized petechiae, gum bleeding. On exam, there is no hepatosplenomegaly or and you don't note any lymph node enlargement. Laboratory testing shows a normal hemoglobin, white blood count, and differential. We don't even need this slide. You better get this right. Okay? You better get this right. And you better answer it too. I want more answers coming in. Pick up the pace. Hit those buttons. 101. Very good. Okay. TTP. Nah, we'll talk. We're going to have a TTP question. And TTP should make you poo your pants. Okay. ITP can, but TTP, you better be pooing the pants. Okay. All right. Not leukemia. Don't have enough cell lines down. Not severe aplastic anemia. Don't have enough cell lines down. TTP, hold that thought. ITP, classic story. Petechiae bruising. Hey, come on, this is primary. This is not this is primary hemostasis, okay? Remember when we talked about too many platelets? I know the magnifications are a little different, but when we talked about that iron deficiency and you could see 10, 15 platelets, right? This is a bigger magnification, so a higher magnification. So you're not going to see, quite as many. but you had to hunt around. Let me promise you, when you were on a lower mag, you were hunting around and you couldn't find any platelets. And when you found this platelet, what jumps out at you about this platelet? Big, right? Why is it big? It's young, okay? Why do you have big, young platelets in ITP? Because the platelets are getting destroyed in the bone marrow. Is there a problem with the factory? Is there a problem with the bone marrow? No. The problem is they're all getting destroyed. So they're big. And so what you're going to see is you're going to see an MPV. It's not a hard, like, oh my God, I see this big MPV. It's got to be ITP. You see the MPV and what your thought is boom. That gives me a clue. If it's greater than 11, 12, you're really thinking something like that. So ITP is immune-mediated thrombocytopenia. And it's destruction of antibody-coated platelets. They get gummed up in the spleen. The body had a cold, generated a bunch of antibodies to fight off that virus, made some bad antibodies that are attacking the platelets. The platelets are coated with antibodies. They're getting jammed up in the spleen. The classic here is that it's normal except for petechiae and bruises. These are not sick kids. I still remember going to see, my PGY1. I'm in continuity clinic. I see this kid's got thrombocytopenia, and I'm wondering, I want him to then already be a cancer doctor. Maybe this is going to be leukemia. And like my very seasoned mentor came in and said, see the child running around the exam room there? That child does not have leukemia. Okay? And don't let the kid run around. He only has platelets of 4,000. Okay? Isolated thrombocytopenia, mixture of normal and abnormal patients. It's a diagnosis exclusion. This is one time. Do not play the Willie Sutton card. This is the Willie Sutton. We do not marrow these kids unless it is completely atypical, unless you have other cell lines down and it does not get better. There are four management strategies. Let's make a note on this slide because we're using some a little more. If everything is normal, you can give these kids steroids. And here I am, a leukemia doctor, telling you it's okay to give somebody steroids. Because if they have a normal exam, no adenopathy, no organomegaly, they don't have other cell lines down, studies have shown you're not going to miss leukemia. It's okay to give them steroids. It would be okay to give them IVIG. It's really expensive. It would be okay to give them, and write this down, it'll be on next year's slide, it would be okay to give them Winro. What is Winro? The anti-D antibody. So you got to make sure that they're D positive, okay, or RH positive, right? So what you do is, why the hell does that work? Giving them Winro, right? So what you do is you create a little hemolysis by giving the anti-D. It binds to the red cells that have the D antibody, big D, right? And then those all get sucked up in the spleen, and the spleen doesn't suck up the platelets as much, and the platelets come up. So you can do steroids, IVIG, or Winro, anti-D antibody. Or who trained at Southwestern? Did anybody train at Southwestern? If you've learned from George Buchanan, one of the best hematologists in the country, you can do the fourth option, which is the least expensive: observe and counsel. And it often makes a lot of sense because the bleeding risk, the risk of severe bleeding in ITP does not depend on the platelet count. What it depends on is if you got mucosal bleeding or hematuria, you have a higher risk of you've already had some, or wet purpura, you've already had some spontaneous bleeding. So you could have that catastrophic head bleed. But if you don't have any of those things, the chance of catastrophic head bleed is really low, and it's not related to your platelet count. So you can sit tight. I think, all three of those options, steroids, IVIG, and Winro can work. They all maybe won't work. About 2/3 of kids resolve their ITP in the matter of, with one treatment. About, older children are more likely to develop chronic ITP, which is ITP which lasts more than 6 months. Okay. 16-year-old girl of Mediterranean descent presents to the emergency room department with bruising and yellow eyes. Significant labs include hemoglobin, platelets, super elevated LDH, big Billy, reticulocyte count. Okay. This is the poop your pants disease. Okay. It's very rare, but I've seen it a couple times. And this was from her history. I think these were her labs. So which of the following is not true about her condition? I apologize for the negative question. Will she have schistocytes? This condition is life-threatening and must be treated emergently. Well, if you're going to poo your pants, that better be true. Condition is associated with an increased risk of developing lupus. The underlying pathology is autoantibodies against platelets. So what disease are we talking about? Maybe her creatinine was up too. Maybe she had neurologic symptoms. So what disease are we talking about? Okay. We are talking about TTP. And interestingly, it is associated with a risk of developing lupus. There's some good papers on that. So you could go lupus and TTP. If you have TTP later in life, you can have lupus. It is not an autoantibody against platelets. TTP is thrombotic thrombocytopenic purpura. It is a thrombotic microangiopathic hemolytic anemia. Okay? Before we were smart enough to, had good therapy and had things we do, you'd see a pentad appear, thrombocytopenia, microangiopathic hemolytic anemia, meaning you're forming these little clots, and so as blood goes through them, it shears the red cell, right? Breaks them up, and then you get these schistiocytes. Neurologic dysfunction, more classic in adults, and then renal dysfunction. Why? Because you're getting little clots, and the kidneys don't like little clots on blood vessels going to them. So this is what a TTP slide looks like. Do we all appreciate the schistiocytes? Okay. Look at them. Wow. Where did all the platelets go? Again, I probably should have done a better job teaching this, but again, 5. That's what I want to see. 5 in 10. Remember that IDA slide? Boom. Lots of them. They were overrunning your slide. Can't find them very well on here. This is really fascinating pathophysiology. It's associated with reduced activity of the von Willebrand factor. Let me get my tongue untied. So what you have is you have this protein called ADAM-TS13, okay? And what ADAM-TS13 is, you have von Willebrand factor, and it can show up as these large multimers. And these large multimers are super active. They plop down, they start bringing platelets to them, they start forming thrombi like crazy. They have a really important role in forming good primary hemostasis. But got to keep them in line, and that's what ADAM-TS13 does. And so if you have an antibody to ADAM-TS13 and your ADAM-TS13 level is way down, what happens? You got too many big multimers, okay? And you get the microangiopathic stuff going on, okay? So the pathophysiology is antibodies to that ADAM-TS13. Okay. 4-year-old boy, history of severe snoring, develops life-threatening bleeding following elective tonsillectomy. CBC shows a platelet count of 135,000, an MPV of 12.5, PT 11.4, PTT 35.5, fibrinogen is 640. Okay, he's bleeding. Let's think about this. 135,000, should he bleed? No, I don't think so either. MPV 12.5. Big, little? Big. Okay. PT 11.4, normal? Yeah. PTT 35.5. Yeah, normal. Fibrinogen 640. Elevated? I don't know. Yeah. So something's got to be, so with these numbers like they are, is this likely going to be a qualitative or quantitative defect of something? Is something missing in his clotting process? Probably not. It's probably something not working. So this is a really, really, really hard question. Okay? And so, do you think he has antiplatelet antibodies? No, that's ITP. He wouldn't have any platelets. Lupus anticoagulant. Do they have problems with bleeding? No, they clot. Okay. Congenital factor 7 deficiency. I don't think so. Ought to affect your PT, shouldn't it? You know? Ought to be real important. Deficiency of glycoprotein 1B? What the hell's that? A mutation in protein 4.2. Good God. You guys are smart, okay? Because this is a qualitative platelets disorder, okay? And there are a bunch of different ones. And they're hard, okay? This is Bernard Soulier, often mild thrombocytopenia with big platelets, and it's got a deficiency in glycoprotein 1B in the platelet membrane, and that's why it doesn't work. You can also have Glanzmann. That's going to be, poor platelet aggregation response to ADP and epinephrine. I think you're just going to have to go back and go those. Those are so detailed and so picky that I don't really kind of know where to go with on this, other than just to tell you to, go back and at the last minute cram a few things in on some of these, because these are hard. I mean, these take me. I go to the books. I go to look these up and really think hard about how to work these up. Only like the real platelet gurus, in my field are real comfortable with all these. The only time we get these questions right is when we've all been studying for our boards, our heme boards, not your boards. A 2-year-old child in septic shock in the ICU has multiple non-blanching purple lesions of various sizes on his trunk and extremities. He's noted to have oozing from an IV site. Which of the following statements is not true? D-dimers will be elevated. Platelet count will be decreased. Fibrinogen will be decreased. Factor 5 and 8 levels will be elevated. PTT will be prolonged. Okay? All right. What does this kid have? DIC. So this question went from you had to recognize that this child had DIC to now think about what's true in DIC. Okay? All right. Are your D-dimers elevated in DIC? Yes. By definition, DIC means your platelets are going to be low. Yes. Fibrinogen will be decreased. Usually. I mean, I know some of you guys are saying, hey, fibrinogen can be elevated because it can be an acute phase reactant. But if you got really big DIC, you're using up that fibrinogen. Remember, what's DIC? You're making clots and breaking clots and doing it really fast. So you're not going to have fibrinogen, because I don't think we test for it anymore, but there used to be something called fibrin split products, that would be elevated. So you're not going to have elevated fibrinogen. Factor 5 and 8 levels will be elevated. No, that's the correct answer. PTT, yes, will be prolonged, because you're using everything up. Okay. Disseminated intravascular coagulation characterized by bleeding and clotting. Management, everybody knows this from medical school. Treat the underlying disorder. Decreased platelets, prolonged PTT, decreased fibrinogen, elevated D-dimers and fibrin split products, though I haven't ordered that in years. Decreased clotting factors because you're consuming them. Okay. 1-year-old male infant presents to the emergency department with continuous oozing from a circumcision. Exam shows bleeding from the circumcision site. Hemoglobin 7.9. The remainder of the CBC is normal. Okay. Von Willebrand, antiplatelet antibody test, DIC, PT, PTT, INR, factor 8. What do you want to do? I think Willie, this might be an exception to the Willie rule. You guys are going to throw rocks at me. Get them out and throw. I like PT, PTT, INR for this one, okay? Because it can be, because what we're going to talk about with hemophilia is, although 8 or hemophilia A is the most common, I think you want to establish, first of all, that there's a problem with secondary hemostasis and that there's a prolongation with PT. You want to establish that there's one of your clotting factors is wrong. So I respect that, but we're going to have to fight about it. So hemophilia can be a deficiency in 8, 9, or 11. Those are called hemophilia A, B, and C. Hemophilia can be mild, moderate, or severe, and that all is driven by the amount of factor you have. Classic presentation of hemophilia is post-circumcision bleeding. Epistaxis may be soft tissue bleeds, muscle hematomas, joint bleed, joint bleed, joint bleed, joint bleed, post-traumatic surgical bleeding, and intracranial bleeding. Lab features, PTT prolonged, low factor levels. So that's why in this case, I know I've overemphasized Willie Sutton, but this is one time. Boy, that's a tough one, but I would have gone against Willie. Management factor, factor replacement, education, physical therapy, prevention, prophylaxis. A good hemophilia clinic is multidisciplinary. They're going to have the physical therapists there working with them. Okay, 12-year-old girl presents to the emergency department with pallor and fatigue. She has just reached menarche and has had bleeding for 8 days. CBC shows a hemoglobin of 6.7 with other counts normal. So what's going on? She's going to have a low factor 8. Is her INR going to be through the roof? Is her lupus anticoagulant testing going to be positive? She can have something with her von Willebrand factor, or we can have that antiplatelet antibody testing. Okay. Excellent. Who's the guy who wants to order antiplatelet antibodies? Okay. Because I don't know if I've ever really ordered them. Because I don't think they ever really help. I mean, we don't use them you have antiplatelet antibodies in ITP, but we never test for them. We just presume they're there. So whoever you are, I'm throwing you out, okay? All right, this is, again, I cheated and kind of gave you the answer ahead of time. But this is a classic presentation for von Willebrand's disease, okay? And von Willebrand's disease, there are many types. There's 1, there's 2A, there's 2B, there's 2N. I think it's most important for you to understand 1 and then the difference between 2. Okay? So, if you have type 1, you are going to have low levels of von Willebrand factor. The antigen level and the activity level will match. Okay? This can be treated with DDAVP. If you have another type of von Willebrand disease, the von Willebrand factor has something qualitatively wrong with it. So the antigen level will be higher than the activity level. They'll be out of whack. That, to me, is the most important take-home point. If you're sorting out these other crazy types of von Willebrand disease, either clinically or on if you're doing it clinically, you're crazy. If you're doing it on an exam, they were crazy. Okay. A couple things on infant hematology real fast. Actually, it's only one thing because it's a classic question. Term infant who was delivered at home. What does the term delivered at home mean? Translate that to me. Yeah. Didn't get his vitamin K. Okay. All right. Okay. You got it. So he's going to bleed. All right. And he was at home, so he didn't get his vitamin K. So what's his diagnosis? Hey! Okay, the vitamin K dependent factors, I remember by 1972. 10972. You were all born after that. So, okay. So hemorrhagic disease in the newborn, those are our lab features. You get some prolongation both of PT and PTT because these factors are in both pathways. Normal fibrinogen, normal platelet count. Give them vitamin K, give them FFP if it's really bad. Okay. Thank you guys very much.